we're going to talk about increased intracranial pressure. You can see just even small increments of change up in your brain, where all that high dollar real estate is, makes big changes in increased intracranial pressure. So we know that cerebral blood flow has to get all the nutrients, oxygen, glucose, everything to your brain. So look at what, at resting, our brain needs almost 20% of our cardiac output just resting. So you can imagine when any other thing is going on, it needs much more. Now, you'll recall that under normal conditions, the ICP is maintained at like 15 mm's of mercury. So that's what we say is normal, and we're not going to get real excited until it gets over like 20. We'll usually start treating it, sometimes even we'll wait until like 25. But CPP is cerebral perfusion pressure, and that's how much pressure we need up in the head to get enough blood and oxygen to the brain. You'll remember what MAP, which is the mean arterial pressure, and if you take the mean arterial pressure, and if you have a ICP monitor on the patient into their head, then you can subtract what the ICP is and find out what the cerebral perfusion pressure is. So CPP is MAP minus ICP. So the CPP is a pressure gradient over which the brain is perfused with its oxygen and blood supply, all that, everything, nutrients. What we want to do is keep the CPP, the cerebral perfusion pressure, around 80 millimeters of mercury. And that'll give the brain, that'll allow the brain to get all the oxygen and blood supply and all that it needs. So whenever the blood flow is reduced by 40%, like any catastrophic event, then the tissue is going to become acidotic. You remember that. So when 60%, we're going to really be in some deep problems. The EEG is going to be changing. The only way it knows how to compensate is by changing the fluids up there in your brain, and that's what's going to be going on. And when there's an accident, the brain may not be doing the compensating, but the blood's going to be doing it. If there's a bleed or edema or what have you, and it's not going to be good, because that is the most lethal form of compensation, is when the brain tissue gets compromised and displaced by edema or whatever. And that can cause the brain to herniate through the foramen magnum, that big hole that goes from your brain down your spinal column and everything. That's the only place that your brain has to go, because your head's closed and encapsulated. So anyway, let's look at this. If it makes you nervous, don't look at it. We've got something putting a squeeze on your brain and causing the intracranial pressure to be increased, which causes blood perfusion to be decreased, which causes a decrease in the serum of the pH, which we know makes it acidotic, hypoxic. Okay, so when we want to try to increase, we're going to get more vasodilatation, means more edema, which means this ICP gets even worse. So it's a really bad, vicious cycle if we don't jump in and if it can be fixed. Okay, MAP of 50 to 150 doesn't alter the perfusion when everything's normal, when autoregulation is present, when the body's maintaining its own homeostasis. But when we have any problems coming up, get short of oxygen, or we get too much ischemia, or we get CO2 being retained, then guess what? we get dilation, and we get acidosis. Okay, we've blown off too much, then we're going to get alkalotic. Okay, so we got, let me go back, crazy. Any change in the metabolic rate as well. We know that. So who's at risk for an increase in intracranial pressure? And we know this. You recognize that patients with brain tumors are, patients with head injuries are, anyone with a cerebral bleed, babies with hydrocephalus or children with hydrocephalus, edema from surgery, an injury on the head. So all of those things can cause this pressure to get out of whack. Now here's the first sign is a level of consciousness. So we know that's going to be the first place we're going to always go, isn't it? Well, first place usually. There might be other times when we're looking at airway. But anyway, the level of consciousness is usually the first thing to start dwindling off if it has a period for it to do it. If it's just a wham bam, you get hit with a truck and you're in a coma, that's, immediate. But if something's kind of taken an insidious kind of course, then our level of consciousness will be the first thing to go. And these are some terms you should be able to recognize: alert, lethargic, obtunded, stuporous, and semi-comatose. Those might mean different things to different people. However, what we want them to mean is alert is that you're responsive to visual stimuli, auditory, tactile, everything. Disorientation will usually occur first to time, and then to place, and then to person. So usually they will know who they are, even if they're confused, initially. So first thing, they might not know what day it is or what have you. Lethargic, that's when they're sleepy, but they're easily aroused, and they're appropriate when you get them awakened. Obtunded is arousable but confused, and as soon as the stimulus is gone, they fall back asleep. Stuporous, they don't actually become totally conscious, but they respond appropriately to painful stimuli. So they try to withdraw or push your hand away or what have you, but they probably don't get totally awake and able to speak to you. Might just, mumbly, grumbly. Semi-comatose, they respond inappropriately. And they may try, but it's not purposeful. And they may even have decorticate or decerebrate posturing. The pupils, we said the level of consciousness is the first thing. Then we have the pupils. We'll start seeing early on symptoms will be diplopia, blurring, or decreased in acuity of vision. And then later signs, of course, will be change in the size or the response to light or stimulation. Let's see, headache early on, it might just be vague. Later, it might be much more severe and also accompanied by nausea or even projectile vomiting. Respirations, early on, they might be normal, but then later they are decreased, and together with an increasing systolic blood pressure and a decreased pulse. So, and as the intracranial pressure changes, then the vital signs will change also. We'll start seeing deep yawning and Cheyne-Stokes respirations. Change in motor function. Early on, we'll see progressive weakness in the muscles. Later, we'll see decorticate, decerebrate, or flaccid reactions. So, and remember now, we've been talking about say children and adults, but in infants, we're going to see with the increased intracranial pressure, the bulging fontanelles, cranial suture separation, increased head circumference, and the high-pitched cry. And probably the first one of those that we would see is maybe with, no, I'll just leave it at that. That's good. It's going to muck up the water there, and I don't want to. Okay. Here's the decorticate. going, if your arms were hanging down straight, they would be going away from the head, but they're up, away from the cord, going toward the head. That's how I like to look at it anyway. Rigid spine, inwardly flexed arms, extended legs, plantar flexion toward the cord. Decerebrate, arching spine, rigidly extends the arms with the hands rotated outwardly, rigidly extends legs and they're rotated outwardly, plantar flexion. So when we have an increased intracranial pressure, we want to see if we can narrow down what the cause is, and then if possible, let's fix it. A major cause of therapy the major goal of therapy is to figure it out and to then get the pressure back down within a reasonable level. So if they can't do surgery or choose not to do surgery for like a treatable lesion or hypertension or whatever's going on, then they will treat it medically. And by medically, we'll give medications, fluid, positioning, nursing care, and that sort of thing. So, but once it's identified that the pressure has elevated, we need to do something quickly because these patients can deteriorate rapidly and can expire on us. So generally we treat the ICP when it exceeds 20, and sometimes we will see them wait for a little while and try to do some things before they get real aggressive. So we want to try to reduce the volume of blood, prane up there in that space, or cerebral spinal fluid, because we know that's prime property. So we know that the brain, and these are under normal conditions, is 80% of what's up in your head, and the cerebral spinal fluid is 10, and blood is 10%. So just any change in those numbers compromises the other numbers. So when we get a bleed, even though it just might be the size of a nickel or a dime, or getting bigger to a quarter, can make a big difference on the perfusion to the brain. So what do the vital signs look like? Early on, they're relatively stable because our old body's just trying to maintain homeostasis. It's really a fine-tuned instrument. So, and then we start seeing some changes in the blood pressure. You'll see an increase in the systolic blood pressure, and the diastolic will either stay the same or it might even drop a little, and that's called, remember that from your assessment class, physical assessment class, that's called a widened pulse pressure, and that's not a good thing. That's not a good thing at all. And we'll see bradycardia, and we will also see the respirations going down. The temperature early on, it'll usually maintain itself and be kind of normal, and then it starts to increase. And hyperthermia, of course, it causes the brain to swell more. So, and then it's followed by hypothermia as the spinal fluid increases. Now you can look at this as compared to shock, generalized shock. Blood pressure in shock goes down, and to try to compensate, pulse and respirations go up, and the temperature may go down. The pulse pressure goes down. Level of consciousness goes down. And with the increased intracranial pressure, we have the blood pressure going up. The pulse and respiration, where I guess because of where those centers are located in your brain, and with the pressure getting up, then they're not responding correctly, so they go down. Temperature will go up initially, and then the pulse pressure widens, and our level of consciousness goes down. So the main vital signs that we look at, other than level of consciousness, they're just the opposite of what generalized shock is. So we're not learning new stuff. We're just looking at the old stuff and using it a little differently. Okay? Some of our interventions. Maintaining the temperature, we're probably going to try to get it to go a little hypothermic, because that's what we want to do. And we know fever is a defense mechanism that the body already sets up. It's an inflammatory response to infection or any strange damage. So we might want to drop that down a little bit. Blood pressure, we want to maintain it at a high normal. So this is one of those times when we don't want their blood pressure to be ultra low, because it won't perfuse the brain. Even though whatever's going on up there, we still have to have the blood pressure maintained at a normal high level. We're going to probably control their ventilation. We'll avoid hyperventilation the first 20 hours or so, because it causes vasoconstriction, which will cause the pressure to rise even more. We want to prevent hypercarbia. We want to control secretions. However, we will find that suctioning these patients is one of those things that causes the pressure to elevate. So we want to do that real quickly, as fast as we can, as gently as we can, and only when we have to. So very careful suctioning. In fact, we may give them lidocaine IV to help suppress cough, so that they're not, bucking the tube and what have you. All right, administering some meds. We're going to give some diuretics, probably some osmotic diuretics such as mannitol. And I will reiterate this because it sounds like a test question to me. Brain tumors, we give steroids, and for brain injury, we give mannitol to help with the cerebral edema. Well, also, sometimes we will give Lasix to help bring out some of the fluids. Opioids, now we might not initially give them narcotics and all, but then as we know what we're up against, then we will. Initially we might be trying to decide what the signs or symptoms are showing us, and we don't want it to mask any symptoms, but once we know what it is, and if they're in pain, we're going to give them narcotics, because we already know what it is. Let's see, anti-epileptics, because we want to prevent seizures. So antihypertensives, beta blockers, neuromuscular blockers. And if you remember from your respiratory days that if we've got a patient on a ventilator, not only do we want to give them something to take the edge off, we're probably going to kind of knock them out, because that is very uncomfortable to be on a ventilator. So we're going to give them maybe some paralyzing agents and some drugs to help cloud their minds so that they can rest. We'll be doing fluid and electrolyte management. We may do, if we put in a ventricle drain up in their ventricle or up in the parenchyma in the brain tissue, we may be performing ventricular drainage for them to help get the ICP down. And we want to coordinate their activities and their rest, because sometimes any moving, turning, twisting, suctioning, visitors, all those kind of things will cause an increase in the intracranial pressure. So we may want to try to limit that, keep the lights low, not make a lot of racket in there, get in and do our stuff and be gentle with the patient. Let's see what else. Okay. Force positioning, like I said, we want to avoid any odd, wad kind of head cranked over to the side or whatever. So they may put rolls to each side of the head to keep them from having their neck kind of twisted. The head of the bed usually will be up 30 degrees unless they've got some kind of spinal injury, but we'll rule that out pretty quick. And put collars on them, take precautions, and usually the head will be up for 30 degrees. Let's see. Okay, so what I meant by this heads here, this little thing, you don't have to memorize that, is just kind of recapping the things we've talked about. Elevating their head of the bed to promote the venous drainage, level of consciousness, we're going to be doing neuro checks on them, checking their pupils, airways, certainly we're always checking that, drainage from ears or nose, otorrhea or rhinorrhea, maybe signs of cerebral spinal fluid leaking. If it is, that's going to be a straight line to the brain, for infection. If it is a leak, it would test positive for glucose. Also, you can do apply a sterile dressing over those areas. Also, you can do the halo test, get a white, like a gauze, and get some of the drainage. And as it drains, or as it dries out on the sponge, it will make a circle, and the inside will be lighter than the outside, and the outside will usually have a little bit of a darker yellow or even a little blood tinge to it, and that's called a halo sign. Okay. And certainly safety and seizures, we'll be looking for that, keeping them safe. Okay, moving. That's just about all we need to know about that. I mean, that's a lot to swallow, I know.